Afternoon. It's Dr. Michael Jacobs, live from Miami, and we're going to talk this afternoon on some different directions that are available for treatment. And the options that we're talking about this afternoon is what's better for me, intrauterine insemination versus in vitro fertilization. In other words, IUI versus IVF. First, it's important for people to realize that prior to making a decision on treatment, it's important to have an evaluation as to what the cause of the couple's infertility is. On the male side, it's mostly looking to see the assessment of the sperm, looking at the counts, motility, and morphology. On the female side, it's looking at the anatomic questions. Is my uterus and tubes normal and working properly? Two, does ovulation occur, doesn't occur? And three, do I have good ovarian reserve? And by ovarian reserve, we mean the quality and quantity of eggs that are left in the ovary. And the answers to those questions are going to be very helpful in guiding us in making recommendations as to what is the best means of proceeding with treatment going forward. When we're treating couples, they fall into three basic categories. One is using ovulatory drugs, and this becomes very important in a couple who the main cause of infertility is that they're just not ovulating properly. You'll get a sense that this is what's going on by the fact that cycles, instead of being 25 to 30-day intervals, would be very infrequent, or very short cycles, or very long cycles. But if you fall out of the basic range of 25 to 34-day intervals, one needs to think that I might not be ovulating properly. When you're using ovulatory drugs to restore ovulation, then usually you start with oral medications and then injectables if the orals don't work, or sometimes a combination of the two. And you use those alone initially, and you don't need to do anything else. You just use the fertility drugs, make sure the sperm's good, and try that for a few months. And if that doesn't work, one can add in intrauterine insemination. Or if there's any suggestion of the sperm problem, if it's a little bit low, if it's difficult to time relations at the correct time of the cycle, or it just isn't working with just restoring ovulation by itself, then adding insemination makes sense. Now, the two ways we treat people that are ovulating normally are either with intrauterine insemination. A lot of people know this as artificial insemination, but there's nothing artificial about it. It's taking the sperm at the time of ovulation. The male partner would provide us a sample of sperm. We process it in the lab in a protein media, basically. And what that process does is it isolates out the best swimming sperm, the more higher concentration of normal appearing sperm, and we use that to inseminate in the uterus, so that with a very fine catheter that's less than 1 millimeter in diameter, we can place that into the uterine cavity at the time of ovulation and get the sperm closer to the eggs so that it has an easier time to find the eggs. So intrauterine just means that we're putting the sperm directly into the uterus rather than it being deposited in the vagina, which is where it would occur naturally with intercourse, and rather than putting it in the cervix, which is just at the entrance to the uterus, basically. So by doing this, what advantage does it have? It's kind of same if I'm sitting here in my office. If I was the egg and I had ovulated and the tube picked up the egg, and now I'm in this 3-day transit period for the egg is being transported into the uterine cavity. The fertilization process usually takes place in the fallopian tube. So the sperm that would normally get ejaculated in the upper vagina have to find their way into the cervical canal and swim all the way through the uterus and swim out to the tube and find the egg, basically. So if I'm here in my office, and an analogy would be if the sperm were out in the parking lot and I was in the office, the sperm would have to find their way into the office building, find my office, find where I was hiding within my office, and fertilize me as the egg. Whereas With intrauterine insemination, you're putting that sperm right outside the door to my office, and it just has to find the egg by itself. But you're putting them in close proximity with each other. The sperm still has to fertilize the egg on its own, and once that fertilization process occurs, the fallopian tube has to transfer that embryo back into the uterus. So everything is happening physiologic naturally. Fertilization is occurring naturally. The transfer of the embryo back to the uterus is occurring naturally. The embryo is implanting the way it normally would. The only thing we're doing is giving the sperm a little boost in that we're getting the best quality sperm and putting it closer to the egg in the hope that by getting them close together, the rest of the process will occur. The alternative to that is in vitro fertilization. And with in vitro fertilization, what's done is the woman is put on fertility drugs to produce multiple eggs. So the first concept when we're using fertility drugs is what are we trying to accomplish with that? If we break patients down into three categories, the first one being the patient who doesn't ovulate at all, the second category being the patient who's ovulating, but either the sperm count's a little bit low or they're not getting pregnant, and we want to do intrauterine insemination. And the third patient is the patient that we're preparing for in vitro fertilization. The goal that we're trying to set with the use of fertility drugs changes with those three groups of patients. In the first group, if you're not ovulating properly, we're trying to restore the process of what happens by itself. And in a human, it's producing one egg and occasionally two eggs in a cycle. We don't want 5 and 6 eggs because we don't want people giving birth to basketball teams or hockey teams or anything like that. So we're trying to take someone who doesn't ovulate at all and get him to produce one egg. And that's a great accomplishment because we're restoring what wasn't working properly. And then by doing that, either with exposure, with relations at the correct time of the cycle when ovulation is occurring, or with intrauterine insemination to get the sperm closer to the eggs, we can maximize a normal pregnancy rate per cycle. And in someone who doesn't ovulate and you put them on a fertility drug to get them to ovulate, whether you do inseminations or not, as long as the sperm is reasonable, we would expect 18 to 20% pregnancy rates per cycle because that's what the normal pregnancy rate would be in somebody under 40 years old. It would be about half that in someone 40 to 42. In somebody who is not getting pregnant, who we're using a combination of an ovulatory drug with intrauterine insemination for a slight compromise in the sperm count being a little bit low, but not too low. Then we're okay, or unexplained infertility. We don't mind 2 or occasionally even 3 eggs ovulating with these ovulatory drugs. We really try and avoid more than those numbers being produced because we're trying to avoid multiple birth and the complications of multiple birth. So in someone where we're doing inseminations because the sperm count's low or unexplained infertility, we aim for between 1 and 3 follicles being developed when you look at it by ultrasound, and within each follicle potentially lives an egg. So again, our ideal is probably 2 or 3 for unexplained infertility, at least 1 obviously, but preferably no more than 3. Someone's producing 5 and 6 eggs, that cycle should really be canceled to try and avoid a high order multiple birth. With IVF, though, it's a different tack. With IVF, we're trying to stimulate the ovary to produce multiple eggs because the more eggs we have, the more embryos we get at the end of the day. And because of that, we use injectable fertility drugs rather than oral fertility drugs. And by using these for between 9 and 12 days, instead of producing 1 egg in this cycle, we try and override that natural response. And ideally, we would get 15 or 18 eggs in a cycle to work with, which would give us excellent numbers of embryos and a great chance of getting people pregnant. So, when is IUI the best choice? IUI is good when we're just trying to treat unexplained infertility as a first step. approach. It's good in a couple where the only reason they're not getting pregnant is the sperm are just not 100% normal. But a normal sperm after you look at it, you should have at least 10 million motile sperm in the sample, or a concentration of at least 15 million per cc. 40% of the sperm should be motile. You'd like to see at least 4% of them have a normal oval shape when you look at it under the microscope. Whenever the sperm parameters are not within that normal range, IUI becomes a nice way to start out treating a couple. If sperm counts get down under 5 million, you don't see very good chances of success with inseminations, and we use fertility drugs to increase the likelihood of success. It helps two main reasons. One, we know exactly when ovulation is going to be occurring within a 24-hour window, usually within a 12-hour window. And two, we often will get more than one egg, but not 3, 4, and 5 eggs to ovulate. So we get 2 or 3 eggs to ovulate, and with that, there's a better chance of getting pregnant in a cycle than not doing the two together. So we usually recommend using an ovulatory drug combined with inseminations, because we get better pregnancy rates than inseminations without an ovulatory drug. Our goal is to get 2 or 3 eggs to ovulate and to have good timing of when the sperm get into the uterus. It's used mostly in patients with a slight decrease in the sperm parameters, a mild male factor, and it's also can be used as a first-line approach to unexplained infertility. IVF is a very big advantage because you're fertilizing the egg outside the body rather than in the tube. So in cases where sperm counts are low, where motility of sperm is low, even if the counts are okay, and in cases where someone's just not getting pregnant and it's unexplained, and one of the explanations of unexplained infertility is the sperm just don't fertilize the eggs and everything else is okay. So by using IVF, we have the major advantage of that you can stimulate the ovary to produce eggs, aspirate the eggs in the middle of the cycle, and then in the laboratory in a dish under the microscope, you can take a single sperm and inject it into the egg and force it to fertilize. So in essence, if we have 12 eggs that are good quality, we need 12 live sperm to work with in order to fertilize these eggs. Whereas when you do intrauterine insemination, to get good results, we need at least 5 million sperm per cc to start off with in order to have any sense of success rates. And success rates vary depending on who we're treating and how we're treating them. If you take somebody who doesn't ovulate at all and you put them on an ovulatory drug, you restore ovulation, you get a normal pregnancy rate for that cycle of treatment, which in somebody under the age of 40 is going to be around 18 to 20%, someone 40, 41, 42, more in the 10% per cycle range. And most pregnancies occur in the first 4 to 6 cycles. So in someone who doesn't ovulate at all, it makes sense to try that for 4 to 6 cycles. And then if they're still not pregnant, we truly have unexplained infertility. And at that point, you can either use injectable fertility drugs with insemination, or the better approach is to go directly to in vitro fertilization. However, if you have somebody who has diminished ovarian reserve, if you have someone who's ovulating normally and just not getting pregnant, unexplained infertility, the sperm counts are reasonable, there's nothing to really explain why the couple's not getting pregnant, and we do intrauterine insemination with a fertility drug. This is a couple who's tried to get pregnant for a year and has not been able to. If you haven't gotten pregnant in 12 months, and if you look at couples who are trying to get pregnant, 85% of couples will be successful in the first 12 months. And if you do nothing over the next 12 months, in the month 13 to 24, you find that only 10% of people over that 12-month period are going to succeed. So if you haven't gotten pregnant in 12 months with good time cycles, then the chance of getting pregnant each month going forward for the next year is less than 1%. If you do inseminations with normal sperm, with a fertility drug, an oral fertility drug like Clomid or Femara/letrozole, pregnancy rates are going to be better than doing nothing, but they're only in the 8% range. So it is 8 times better than doing nothing, but success rates are still pretty low. And if somebody is over the age of 40, you can expect about half those results. If you look at in vitro fertilization, that's a whole different story because our success rates are much higher. Now, let's say you do intrauterine insemination for male factor. Here you have, if the success rates for unexplained infertility are about 8% per cycle with Clomid and insemination or Femara with insemination, if the sperm count is less than optimal, our success rates are going to be lower than that. And when you start seeing sperm counts under 5 million, success rates are really under 3%. So we don't even recommend trying insemination. You can do it if you really want to, but our best recommendation for patients with sperm counts that are low, particularly under 5 million, is just do in vitro fertilization. If the sperm counts are between 10 and 15 million, that's a compromised sperm sample, but it's not unreasonable to do a trial of inseminations for 3 cycles, and if that doesn't work, then consider IVF. In the 5 to 10 million range, it's a matter of what the couple wants to do. We can try inseminations, but pregnancy rates are probably in the 5% range at best, and then as sperm counts get down to under 5 million, pregnancy rates get a couple percentage points at best. With in vitro fertilization, it's kind of the equalizer as far as sperm is concerned, because it doesn't matter whether the sperm count is 2 million or the sperm count is 40 million, totally normal. When you have the eggs in the dish in the laboratory, you can take a single sperm and inject it into a single egg and force it to fertilize. So pregnancy rates with IVF are going to be in the much higher range, and once eggs fertilize with IVF, the embryos develop and you put the embryos back, and if you have a normal embryo that's genetically competent, our success rates with a single embryo transfer should be in the 50 to 60% range. The other factor besides how low is the sperm is the ovarian reserve. And ovarian reserve in a couple is very important, mostly on a woman's side. As you get older, ovarian reserve goes down, and as even in a young person, let's say someone 34, 35, can have a low ovarian reserve. And in a couple where the ovarian reserve is somewhat limited, there are some advantages to going to IVF sooner rather than later. One, you can tell if you've got normal embryos. 2, if we're worried about ovarian reserve and it's constantly going to get worse, particularly in a couple that desires more than one child, it gives the added advantage of preserving fertility if there are extra embryos, as well as getting pregnant in a cycle by transferring an embryo and having it stick. So you accomplish 2 things rather than just one. And it takes the best advantage of somebody when they're younger. So, 2 or 3 month delay in treatment usually is not going to make a big difference in the big picture, but a 2-year delay would make a big difference in someone's ability to get pregnant. So when there's less ovarian reserve, we tend a little more preference is given, a little more emphasis given to moving to IVF a little quicker so we can take advantage of that. But it needs to be put in the context of the patient's full history and why we're doing what we're doing. So if we look at some questions here, patient with 2 IUIs, sperm count in the 2 million range, and there, as I said a few minutes ago, IUI is great when there's reasonable ovarian reserve, normal anatomy, and at least 5 million sperm in my mind to give that a try. At 2 failed cycles, you can try one more time, but my best recommendation would be to go directly to IVF, where we can microinject the eggs with intracytoplasmic sperm injection in the lab. In the question of someone who's 41 with 3 failed embryo transfers, do we recommend IUI or IVF? IVF would be the best recommendation there, even though it hasn't worked before. Again, the big picture matters, but the question is, why did the embryo transfers not work? Did they not work because the uterus isn't normal? Did it not work because there's some other factor affecting embryo implantation, whether they be immunologic factors or thrombotic factors, or whether the embryos themselves were not competent? Were they normal embryos genetically that were transferred? So all those things need to be taken into consideration to try and answer the question, why didn't these cycles work? But IVF is always going to work better than an intrauterine insemination. If the embryos were not biopsied, that would be my best recommendation, because as you get older, the percentage of embryos that form, whether it be naturally or with IVF, changes, and a higher percentage of them are abnormal. So in a woman 41 years old, you can have 70 to 80% of the embryos not being normal. So if you don't biopsy them, odds are we're transferring abnormal embryos. We just don't know it. So doing pre-implantation genetic testing, or PGT, is very important. The anatomy is very important with IUI. The question was, does endometriosis play a role in implantation? It would play a role both in the success of IUI, more so than with IVF. If you've got anatomic disease, either a tube that's blocked, whether it's partially blocked or just distorting the relationship of the tube and the ovary, it makes it more difficult for pregnancy to occur, and IUI success rates go down. With IVF, the question is, with moderate and severe endometriosis, as a group of patients, you tend to see a little lower success rate in general per stimulation cycle, and a lower implantation rate. Now, part of that is patients tend to you get less eggs. There's more adenomyosis in the uterus, which may affect implantation, and that's endometriosis in the myometrial cavity. And so, and if you've had surgery in the past to the ovary might not respond as well to stimulation. So endometriosis can affect IVF by the number of eggs you get. Once you get to the point of having a normal embryo that's genetically competent based on PGT testing, embryo biopsy, then the endometriosis is less important unless it is hidden in the myometrial layer, a so-called adenomyosis. And the implantation rate may be a little bit lower in endometriosis than in patients without endometriosis. So thank you for helping you get pregnant. You're very welcome. And one of my biggest joys is being successful at what we do. A question: after one embryo transfer failure with a good embryo, do you recommend ERA testing? This gets back to the other question as well. What do you do when IVF doesn't work? We try and find out why. And if you have a normal endometrial cavity, a normal myometrium, there are no big fibroids, there's no adenomyosis in the muscle layer of the uterus that might affect implantation. The embryo transfer technically went well, and we put back a normal, good quality embryo. We just don't know why an embryo didn't stick. So what do we do at that point? Certainly in somebody who's had a history of recurrent miscarriage, or someone that's had at least 2 cycles of embryo transfer without a successful implantation, an evaluation should be done for recurrent pregnancy loss or implantation failure. In my own personal practice, I recommend that we have a discussion. If we put one normal embryo into a normal uterus and it doesn't stick, my discussion is usually, if we only expect implantation to occur 60% of the time at best and 10% of them not to develop, half the time a single embryo transfer with a normal embryo is going to be an ongoing pregnancy, and half the time it's not. So if you have 2 cycles that didn't work out, that's a good time to do a full battery of tests. But I usually will have the discussion after 1 cycle that didn't work out with the patient and get their feedback. If they want us to do some testing, then we do 2 levels of testing. Now, when we're looking, we've already done some of the tests for implantation failure when we did a basic evaluation for fertility. We've looked in the uterine cavity with either a hysterosalpingogram or a saline infusion sonogram. We have looked at the uterus by ultrasound. We know we have a normal embryo that went in. We've checked your thyroid levels. We've done cervical cultures. If the embryos have been biopsied for genetic testing, we know that genetically, at least we put a normal embryo back with 98% reassurance of that being the case. So what goes into looking at implantation failure? 3 things, really. The first is looking at, are you producing antiphospholipid antibodies, such as anticardiolipin antibody? There are some other ones, but anticardiolipin is the key one. The second is, do you have an increased tendency to clotting in the microcirculation? So it's a bunch of blood tests to look at the clotting cascade to see if you have a thrombophilic abnormality. The third is to see whether your immune system is overly active and you're producing in excess of what are called natural killer cells. And when natural killer cell activity is elevated, it's felt by some immunologists that instead of it working in your behalf to get rid of something, cells that are abnormal, protects you from getting cancer cells and this kind of thing, is it working against you because it's recognized an embryo as not being self and trying to get that out of your body too, because it recognizes it as foreign. And the last is endometrial receptivity assay testing, or ERA testing. So we normally, if someone's concerned, we normally would do the thrombophilic panel, the natural killer cell tests. They're easy blood tests. They're not overly expensive and can be done locally. In patients with recurrent failure with normal embryos going back in, particularly more than 2 embryos, 2 cycles of transfer, we bring up the discussion of ERA testing. ERA testing is still somewhat experimental. And when frozen embryos are put back, we time it to when the uterus should be responding to the hormones that we're giving you, to have an ideal implantation bed, or what's called an implantation window. When an embryo gets to the uterus, whether it's a natural cycle or whether it's a cycle using hormone replacement, as most of our frozen embryos are transferred in, the lining has to respond to the hormones we're giving you, and it changes the proteins that are secreted in the lining so that in the second half of the cycle, around the 20th day, the soup that's in the uterus, or the Velcro, whatever you want to think of it as, is the most receptive to get that embryo to stick. And so the theory behind ERA testing is that despite giving a standard dose of hormone to a standard patient, and if you look at which genes are turned on and what kind of proteins are being made on a specific day, there's probably a small subgroup of patients that, even though they should react in one way, their uterus is acting slightly different. So that when we think we're at day 20, where we have this 24-hour window of implantation when the uterus is receptive to an embryo sticking, and the same thing occurs on a natural cycle, if the embryo gets to the uterus, because we put it in there, and the uterus isn't ready for it, or is sort of overcooked, we've passed the window, then it's not going to stick as well. And so the question is, how do we know whether we're in that window properly or not? Now, most people are, based on many years of experience, but if you start testing more on a molecular level for which genes are turned on and which proteins are secreted, it turns out that in patients who have failed multiple cycles in the past, particularly 3 cycles of failure, and you test them, and you'll find that some of those people they're not in sync properly, so that if we looked at their profile of which genes are turned on, which ones aren't, what this test will tell us we should move the transfer up or delay the transfer by 12 or 24 hours. And in some cases it makes a difference, and in some cases it does not make a difference. There's a lot of controversy on how accurate the test is or not. It gets fairly expensive because, one, the test has to be done with an endometrial biopsy. It has to be sent to Spain to be analyzed, and you have to be on a mock hormone replacement cycle. So you're on a hormone replacement cycle exactly as we would do an embryo transfer. We biopsy the endometrial lining, but instead of putting an embryo back, we send a biopsy off to Spain, we wait for the result, and then we change the hormone replacement protocol to modify it to hopefully have a better outcome. And in patients that have failed 3 cycles, who have a biopsy done, and the lining is out of sync, and a change is made, there's an improvement in the outcome. The original studies were not done with a control group where they just tried another cycle without making the change, as well as the fact that the embryos weren't biopsied, so they don't know if they put normal embryos in or not. So there's still a lot of information that needs to occur. My usual recommendation is not to do an ERA assay after 1 failed implantation. Certainly to consider doing thrombophilic testing and natural killer cell testing after 2, but to have the discussion after 1 failed cycle with a normal embryo. And certainly, if more than 2 cycles haven't been successful, we can consider ERA testing, and we leave it up to the patient if they want to have that done or not. If there's adenomyosis present, you really can't remove adenomyosis surgically. Adenomyosis is when the endometrial lining invades the muscle wall of the uterus. Unless it's folded itself up in a little ball so it looks like a fibroid where you can potentially resect around it, you can't really resect adenomyosis per se and have a good uterus result. It's better to treat it hormonally. It will respond hormonally where you suppress the ovarian production of estrogen and progesterone with Lupron. And with that, you'll notice some shrinkage of the adenomyosis over 3 months. The problem is it comes right back. So in patients with mild adenomyosis, we still do embryo transfers. We see pregnancies. In all honesty, we've seen pregnancies in patients with severe adenomyosis. We've seen pregnancies improve where they failed first, and then we suppressed them with Lupron for 3 months, and then did the embryo transfer on a cycle of hormone replacement, and we had a better success rate after suppression than prior to that. We've had patients that get pregnant with the adenomyosis there, but there's no question that adenomyosis will decrease your pregnancy rate, decrease your implantation rate. If you're having recurrent failures with adenomyosis, and certainly trying Lupron suppression for 3 months and then doing a transfer, if that still fails, then one really needs to consider the potential of a gestational carrier going forward. Question of an individual, how do I figure out what's best? Again, that's speaking with your doctor, talking to them about your whole situation, and deciding if intrauterine insemination is a good option or is IVF a better option. Another question here is with Clomid, is increasing the dose of Clomid increasing the chance of getting pregnant? It depends on why we're using the Clomid. If it's to restore ovulation, the answer is no. The best dose of Clomid is the dose that produces 1 egg in a cycle, and that'll minimize any side effects from it, and we've fixed what is not happening. Getting the sperm there at the right time will maximize things. Going from 50 to 100 to 150 milligrams really doesn't work with no monitoring involved. If you're being treated for unexplained infertility or low sperm counts, and with the Clomid, we're only producing a single follicle, a single egg ovulating, there may be some advantage to upping the dose a little bit to try and get 2 or 3 eggs to ovulate, or to use a combination of Clomid and low-dose injectable fertility drugs. But if we're treating an ovulatory patient to get them to ovulate who didn't ovulate, then there's no benefit of increasing the dose. Question, is irregular period after breastfeeding for a year normal? It can be. Question of hysterosalpingogram, it was normal, labs are perfect, and ovaries look great. The question here, usually you go back to, after breastfeeding, similar to someone who's been on a birth control pill for a couple years, you tend to go back to the bleeding pattern that you had prior to that event taking place. So if you were irregular before getting pregnant, you're going to be irregular after getting pregnant. The questions that need to be asked is, was your delivery normal? Did you have excessive bleeding during delivery at all? Was there any insult to the hypothalamus and pituitary from severe blood loss? But if it's a year after you stop breastfeeding and your cycles are irregular, that's a good time to come see us. We'll do some tests to find out why they're irregular. Is there, the pituitary hormones, thyroid, prolactin, FSH, are they normal? We'll check ovarian reserve. And then once we know what the answers to those questions, if there's something directive that we can treat to make things more normal, that's the first step. If everything is just consistent with an ovary that's not ovulating properly, then use of an ovulatory drug with or without insemination would be the way to go at that point. Endometriosis surgery, usually we try and avoid that nowadays because IVF is so successful, and unless there's really, if it's going to compromise, if we're going to be compromised in getting eggs, if you have big cysts on the ovary, then they need to be corrected before doing in vitro fertilization. I don't recommend IUI with ovarian cysts that are endometriosis because they're just going to make the endometriomas grow and get bigger. With IVF, when you stimulate somebody, you're going to be compromised. Anytime there's a cyst in the ovary that's more than 2 centimeters, statistically you produce less eggs from that ovary. On the other hand, if one has endometriosis in the ovary, we have to balance the insult to surgery and going in, removing the cyst, and trying to preserve as much normal ovary as we can versus the fact that you can compromise that ovary from doing surgery. So if you're doing endometriosis surgery for ovarian cysts, endometriomas, if they're small, I would prefer to avoid surgery and do in vitro fertilization and work around the cysts that are there, and we do our best not to inadvertently enter them and aspirate them at the time of the egg retrieval. If they're big and they're basically preventing us from getting to the ovaries easily, or we're concerned that it's not going to allow us to stimulate properly or safely retrieve eggs, then you need the cyst removed prior to that. In general, if there's suspected endometriosis or previous history of endometriosis and we're doing IVF to get pregnant, then I usually don't recommend surgery. Why is IVF better than surgery in general? Because the pregnancy rates are much better with a single cycle of IVF with one normal embryo that's genetically competent. We get a 50-60% success rate. If you have somebody with moderate to severe endometriosis and you do surgery and everything else is normal and you do nothing else for the next year, over a period of a year, you'll find that about a third of those, 30% of those people may get pregnant who've had moderate to severe disease. So it gets into what's best for you individually as a patient and why are we doing the surgery in the first place. Some other questions. Another thank you, Dr. Jacobs, for helping me get pregnant. I love those. Thank you so much. You're very welcome. We dealt with that one. What do I suggest at this time? IVF, that IVF, old that IUI hasn't worked in the past, diagnosed with endometriosis, PCOS, and birth control pills having regular periods because of the hormones. Okay, so this we get into multi-factors playing a role here. If someone with PCOS is not ovulating, is going to need some form of fertility drugs. That means we're using at least ovulation induction. Insemination may help with the success rates there. If there's endometriosis present, then IVF is the ideal way to go because it gets around both issues. It gets around the endometriosis that's hidden there. It gets around any scar tissue that's there. It takes the embryos that are developing normally in the tube out of that environment and lets them develop in the dish, and then we can put them in the uterus. So we bypass the peritoneal space, basically. So IVF is terrific in a situation where IUI has not worked, particularly when we have confounding factors such as not ovulating properly, and there's a suggestion of anatomic disease present. IVF works great for anatomic disease. It gets around any issues of ovulation, gets around any issues of fertilization. Question of, do we consider natural killer cells 10.1 high? The upper cutoff is 10. I wouldn't consider 10.1 very high. If it's suppressed with intralipids and there was a past history of implantation failure or miscarriage, one can consider using intralipids, but it's pretty empiric in that situation. So I think we've answered most of everybody's questions. It's a great topic, and it's a topic that needs to be individualized to the patient at the time. We have to take all things into consideration: the patient's age, their ovarian reserve, the anatomic issues, why we're doing it in the first place, and what kind of expectations do we have of any treatment being successful. And I would encourage everybody, whether they're my patients, my partner's patients, or somebody else in the community or elsewhere's patients, to please ask your doctor the right questions. Okay, we've got these, this is what you recommended for treatment. What options do I have? What alternatives are there? What are the expectations of a good outcome? And that's how you get the answer to the question. In general, IUI can always be tried unless the sperm counts are very low or there's severe anatomic disease, but IVF will always give you a better pregnancy outcome. So I'll leave it at that for this afternoon. I thank everybody for joining us. If we haven't answered your questions, or please come in and see us. We're doing Zoom consults all the time, which work great. They're very time efficient for everybody, and we're available to you to get you pregnant, expand your family, and realize your dreams of having that child. So, and for those that made comments thanking us and me personally for our care and not giving up on people, you're all very welcome, and it makes us feel great hearing that. And thank you for joining us this afternoon. Have a good day.